Hello, everybody. I'm Juan Valle. I'm a professor and medical oncologist at the University of Manchester and the Christie in Manchester, UK. I'd like to thank the organizers of the conference for the kind invitation to come and discuss with you the management of urgent symptoms in cholangiocarcinoma patients with biliary stents or drains, really leading to the Delphi panel guidelines, and I will take you through that process over the next 15 minutes. These are my disclosures. So many of you will have heard us discuss biliary obstruction, but I just want to quickly revisit what it is that we mean when we talk about biliary obstruction. So bile is produced within the liver and is then released. It's stored in the gallbladder. And then at the time when we eat, the gallbladder contracts and the bile then is moved along the bile duct into the duodenum, which sits here, to allow it to mix with the food. It helps with digestion, converting fats into fatty acids, for example. Now, you'll have heard about biliary obstruction. You'll have also heard about the different types of cholangiocarcinoma. If you have a large intrahepatic cholangiocarcinoma just sitting here towards the edge of the liver, it doesn't really matter how many bile ducts you block. It's not really going to cause much of a problem. However, if you have a cholangiocarcinoma sitting at the hilum, so a perihilar cholangiocarcinoma here, right at the trunk of the biliary tree, or anywhere downstream from that, so this is distal cholangiocarcinoma, then you can see how any blockage will then have a much greater impact. The problem is that once the bile ducts get blocked, it can lead to life-threatening complications, which, if not relieved, can become life-threatening, and some patients, unfortunately, may even die, usually from superadded infection. So it is important that we spot biliary obstruction. In terms of symptoms, some patients have malaise, feel generally unwell. They develop jaundice when the skin yellows, and sometimes they get lots of itching or pruritus, as we call it. The stools can become pale, the urine can become dark, and if there's infection, then they can also develop fever or chills, shivers, rigors, and they have different names. In terms of blood tests, we can confirm this by an elevated bilirubin and often also an alkaline phosphatase. Scans are then usually used. These may include an ultrasound scan, a CT scan, an MRI scan. All of them give us slightly different information, but ideally they confirm that we're dealing with biliary obstruction and also allow us a little bit of a roadmap to know exactly where the blockage is and how it may be dealt with. It's also important that we look for infection. Sometimes the white blood cells are elevated, not always if patients have had chemotherapy, and blood cultures are also able to identify if there is an active infection within the bloodstream. So I've alluded to the fact that this is important and potentially life-threatening. It is an emergency. Not in every case, particularly if an infection hasn't set in, but if an infection has set in, then the important first steps are things like rehydration, management with antibiotics, correcting blood clotting. Sometimes there's a vitamin D deficiency. Sometimes the infection itself can cause abnormal blood clotting. And then monitoring fluid balance, making sure that the kidneys are working together with the blood pressure. All of these are important elements in emergency care. Oxygen may also be required, and it's only really once patients are stabilized that we can then plan for the relief of the biliary obstruction. Now, that can be done a couple of ways, and some of you will have heard about an ERCP or a PTC. These are very long words, which is why we abbreviate them. So on the left, we have ERCP, which stands for endoscopic retrograde cholangiopancreatography. And what that means is that we're using an endoscope, which goes down the mouth, past the stomach, and then to the duodenum. And you see here, there's a tiny little opening called the papilla, and then they can have a look there and find out where the obstruction is, put a very thin wire up across the obstruction, and then be able to put in a drain or a stent that then allows it to open up and lets the bile drain. You can see that that would be most useful if the blockage is quite low down in the biliary tree. And that is the same place down here. But sometimes the blockage is much higher. And in those cases, we often think about a PTC. This is a percutaneous transhepatic cholangiogram. Percutaneous means across the skin. And so what an interventional radiologist will do is they will find the blocked bile duct by putting a needle in and the local anesthetic. And then they can pass this very fine wire across the blockage, going from the top end down, rather than in this case, from the bottom end up. The important thing initially is to get the bile flowing again. As you can imagine, bile that's been sitting there stagnant and blocked is very likely to get infected. So the first thing is, let's get the bile draining. And then the second step is to then put in a stent, a little spring-loaded tube that allows the blockage to be sprung open, and that allows the bile to drain. And these are the different stents and drains that are used. You'll see on the left, these are plastic stents. Some drains are longer than others, some are wider than others. In general, plastic stents tend to be very temporary and short-lived. If patients do need to have a permanent stent, then we often go with metal stents, and you can see here there's a whole different variety. Some have got sharper edges than others, some are more flexible than others, and some, like this one here, will allow a stent to go in the side of another stent through one of the openings, and that gives you like a Y connection or a T connection if you need it, because of the complex anatomy within the liver. So we've now got biliary obstruction that's been relieved. We have a stent in place. Unfortunately, it doesn't end there. Once in place, stents and drains are highly prone to getting clogged by tumor ingrowth, which means that the tumor grows in along some of the holes in the mesh, and that then causes a blockage of the small bile ducts. Bile can be gritty, which is why people get gallstones. So you can develop sludge or indeed gallstones, and you can also get superadded infection on top of that. We know that although gallstones are the commonest cause of cholangitis, which is infection in the bile ducts, in some centers is actually following interventional radiological procedures like the insertion of biliary stents that has now replaced gallstones as the most common cause for severe cholangitis. In malignant obstruction, which is what the case is in cholangiocarcinoma, the rate of infection is anywhere in the region from 20 to 40%. But we also need to take into account that we're dealing with a cancer, ongoing treatment in terms of chemotherapy, and other comorbidities, diabetes, kidney problems, and so on. So this can be a very complex situation to resolve. And we also know that all stents are not the same. So for example, if we look at plastic stents, these are very narrow and they're most likely to clog. If you have an uncovered metal stent, the main problem is this tissue ingrowth that you can get through the side holes. And if you have a metal stent that's been covered in plastic, that makes it a bit more slippery, and that one can actually move or migrate, particularly if patients have already had some treatment. So you don't get the same complications from all of the stents. So what was the Delphi process? This was a process to develop consensus guidelines on the management of cholangiocarcinoma patients with a biliary stent or catheter in place, and those patients who then presented an emergency department for the management in the outpatient acute setting. So it was a very specific situation. Now, the Delphi process is a very strict process, and I'm going to take you through the steps on the left. So the first thing is that we need to develop a theoretical framework. The assumptions we made are that patients have fully recovered postoperatively, they had access to necessary care, they could be transferred to a higher level of care if necessary. There was no do not resuscitate order in place, and patients were not having end-of-life care. Patients were not waiting for a liver transplantation, and patients also had access to all the palliative cares in terms of pain, control of other symptoms, nausea, vomiting, as well as counseling and emotional support. Patients are under active management by an oncologist. They have had all of the necessary tests to confirm whether there's biliary obstruction or not. And we're also assuming that if antibiotics are recommended at the time, for example, of a stent fitting, that that's put to one side, and this is now a process happening later. So the next step is to identify panelists. I'm not going to go through all of the names here, but just to highlight, we've got a mixture here of physicians, nurses, interventional radiologists, oncologists, people involved in academic hospitals as well as community hospitals. So really trying to get a really good broad view of where patients present and what the main problems are likely to be. A literature review, which was kindly undertaken by the Nursing Advisory Board, was able to identify a number of different variables which were important. The bilirubin, either normal or elevated, other liver function, AST and ALT, whether the patient had a fever or not, whether the white blood cells were low, for example, as a result of chemotherapy, normal or elevated, the performance status of patients, how fit they were, ECOG performance status 0-2, meaning fit patients, or less fit patients with performance status of 3 or 4. New or worsening biliary dilatation found on imaging, antibiotic recommendations, whether we should think about inpatient or outpatient, or even no antibiotics recommended, whether a stent or PTC manipulation is recommended or not, and whether the patient was having active treatment. These are the important variables. And then a rating form was developed. This looks somewhat complex, but let me just quickly walk you through it. If we think about here, a patient with a normal bilirubin who also has normal liver function tests and has developed a fever, and in the middle here has a normal white blood count. So we can see that this patient fulfills very specific criteria. In addition, on this half, they have no stent obstruction by imaging, good performance status, and then the decision is, should we give inpatient antibiotics, outpatient antibiotics, or manipulate the stent? And for each of these boxes, or indeed clinical scenarios, of which there were 288, a score was given from 1 to 9, 1 being inappropriate, 5 is neutral, and 9 appropriate. Just to quickly show you, there was one for normal bilirubin, and just to again give you an idea, so a patient with normal bilirubin who has normal liver function tests, develops a fever, and has neutropenia, then if they've got new and biliary dilatation by imaging, inpatient antibiotics, everybody agreed and put a 9 here. They felt that that was appropriate. If somebody had a normal bilirubin, otherwise liver function tests were mildly elevated, had no fever and a normal white blood count, then in fact everybody agreed that inpatient antibiotics were not appropriate. And you can see how this was built up for patients also with an elevated bilirubin. The 288 scenarios in the first round were re-rated in the second round, except for 192, where it was felt that chemotherapy really wouldn't change the decision. And in fact, after the panel meeting, the disagreement that we found decreased from 37.5% down to 10.4%. So we were able to get consensus across the panelists in terms of the final recommendations. And here they are. In a patient with an elevated bilirubin, stent manipulation is appropriate. Inpatient antibiotics are appropriate if the patient is febrile. Outpatient antibiotics may be an appropriate alternative in patients with no new or worsening biliary dilatation unless they have neutropenia. Inpatient antibiotics may be appropriate if the patient is afebrile, so has no fever, but does have an elevated white blood cell or, in fact, is neutropenic following chemotherapy. And it was uncertain if outpatient antibiotics may be an appropriate alternative in this case. And finally, antibiotics are inappropriate if the patient has no fever and has a normal white blood cell count. In a patient with normal bilirubin, stent manipulation is appropriate if the patient has new or worsening biliary dilatation, fever, and is otherwise fit, but is not appropriate if the patient has no new or worsening biliary dilatation. Inpatient antibiotics are appropriate if the patient has a fever. Outpatient antibiotics may be an appropriate alternative unless the patient is neutropenic, for example, post-chemotherapy. Antibiotics, either as an inpatient or an outpatient, may be appropriate if the patient has no fever but has new or worsening biliary dilatation and is either neutropenic or has an elevated white cell count. And finally, antibiotics are inappropriate if the patient does not have a fever and has a normal white blood count. So having developed these guidelines, they have been disseminated. They were presented at the ASCO GI 2017 meeting, as well as the Cholangiocarcinoma Foundation meeting in the same year. And the reason we're presenting it today is that it's also been published in the last year, in fact, in August, in the journal Cancers with Dr. Renuka Iyer as the first author. In terms of next steps, we've completed some of these. We've published the guideline in a peer-reviewed journal. The nursing guideline is available on the cholangiocarcinoma.org website, and you can see this as well as other clinical nursing practice guidelines. In addition, in order for patients to have some ownership, there is also the emergency information card that patients can carry with them when they go to an emergency room in this emergency situation. Dr. Iyer will cover in the next session the real-world impact of biliary obstruction, and future work includes looking at the cost-effectiveness, and our hope is that we can include this in supportive care section of future trials to standardize care. And with that, I'd like to thank you for your attention, and here are my contact details. Bye for now.